All right, so today we'll start with the pulmonary venous hypertension as a diagnostic set. So when we have pulmonary venous hypertension, what is the significance of the presence or absence of cardiomegaly? How does that help us if we're going by the chest radiograph? So we have interstitial edema here, also here vascular congestion, maybe some interstitial edema. This one has a big heart, this one has a small heart. So if we're talking about congenital heart disease, what is the significance of cardiomegaly or no cardiomegaly?
If it's before or after the mitral valve?
So if there's no cardiomegaly, it implies that there's obstruction proximal to the mitral valve. If there is cardiomegaly, then we think of lesions that give us obstruction distal to the mitral valve. But there are also other things that can also give you cardiomegaly and failure, so that the differential for that is longer. So no cardiomegaly, then we think of congenital obstructive lesions at or proximal to the mitral valve. If there is cardiomegaly, we think of congenital lesions that cause obstruction distal to the mitral valve. But there are other things like cardiomyopathy or any cause of left ventricular failure can give you cardiomegaly and, of course, have failure. Right? It's a cause of failure. So I've given you in your handouts some of the causes, some of the things that we think about. If there is no cardiomegaly, if there's obstruction at or proximal to the mitral valve, some of the things that we would consider as congenital lesions. And then the differential, of course, is longer. If there is cardiomegaly, there are congenital lesions that will give you obstruction distal to the mitral valve, but cardiomyopathy or any cause of left ventricular failure will give you a big heart and failure, right? So that differential for that is a little bit somewhat longer. And then I've also given you these differentials too for neonates, pulmonary venous hypertension without cyanosis, some of the things to consider in neonates that might have that. And then if we have pulmonary venous hypertension without cyanosis in the first 2 months, with cardiomegaly, without cardiomegaly, so some of the things that might be considered in the differential diagnosis, so here are some lists for that. So if we start with this case, so we have cardiomegaly here, and then here we have an angiogram, we're injecting the left ventricle. So who wants to tell me what we think is abnormal?
The outflow tract is kind of narrowed.
Well, what do you think of the thickness of the aortic valve leaflets?
It's very thick.
Yeah, they look thick, right? And also, what is this here? See, the injection is in the ascending aorta, and this is a jet coming out from the left ventricle into this, right? So your diagnosis here would be what?
Stenosis?
Yeah, so this is aortic valvular stenosis. Also, the size of the ascending aorta, right? Notice that the ascending aorta, there is a little bit of poststenotic rotation. So stenosis lesions or congenital stenosis of the aortic valve can give you obstruction and will give you a big heart and can result in failure, okay? So congenital aortic stenosis, that can be from, usually it's because of some malformation of the aortic valve. So bicuspid, unicuspid, or dysplastic. The younger the patient, the more severe you consider the valvular abnormality. So in very young patients, a unicuspid aortic valve can give you severe aortic stenosis. And then, of course, if it's severe enough, that will result in pulmonary venous hypertension, failure, and cardiomegaly with left ventricular enlargement. Okay? All right, so who wants to tell me about this case? What do we have here? Anybody?
I mean, the aorta is very small.
Yeah, so what part of the aorta is small?
The ascending?
Yeah, so the ascending aorta here, right, is small, right? So this person is, and also there's some abnormalities also involving the pulmonary arteries, okay? So this is, this condition is called, is it small above the valves? Supravalvular aortic stenosis, right. And what syndrome can this be associated with? Williams syndrome, right. So this is supravalvular aortic stenosis. That can be associated with Williams syndrome. And then there you can also have other vascular abnormalities like narrowed pulmonary arteries or even systemic arteries within the abdomen, right? So supravalvular here, there's narrowing of the renal arteries too. So supravalvular aortic stenosis occurs above the aortic valve. You can see here the narrowing right over there. And then because of the high pressures, you can actually get some dilatation of the sinuses down here below the level of the stenosis. So that is supravalvular aortic stenosis. Okay. What about this? Anybody?
Wait.
Coarctation.
Yes, this is coarctation of the aorta. So here we're looking at the descending aorta here, the left subclavian artery. You can see collateral vessels coming off here, and there's this obstruction right here. So this is a case of severe coarctation of the aorta. Again, it's obstruction, and that will cause a big heart, and that can result in failure. So that's coarctation of the aorta. So in this patient, we have CHF secondary to severe coarctation of the aorta. Okay? Now, what about this case? So here we have big left ventricle. There's mitral regurgitation. That's why we have contrast here going into the left atrium. And then here we see that the right coronary artery opacifies first, and then this happens. So how do we put this together?
Is that aberrant?
What?
Yeah, aberrant.
Like, it's like stenosis, like the beginning of the left.
Well, why are the left coronary arteries opacifying after the right coronary artery?
Aberrant origins?
From where? Where's it going?
Between the aorta and the pulmonary artery?
Was a malignant origin?
Why would that cause it to opacify later?
Because it's impinged, like, between them, no?
Unless it's the origins from the pulmonary artery.
Okay, so what do we call that?
Yeah. Aberrant origin of that long, aberrant origin or coronary artery from the.
Anomalous left coronary artery from
Yeah.
pulmonary artery Al Kappa.
Yeah.
So in cases of Al Kappa, what happens is that you'll have collaterals from the right circulation to the left. There'll be delayed opacification of the circulation on the left side because the flow is actually reversed, and then it goes into the pulmonary artery. All right? So that can be another cause of failure in infancy, is Al Kappa. So origin of left coronary artery from pulmonary artery. And we covered this before. It's the same as Gland-White-Garland syndrome. So when the left main coronary artery originates from the pulmonary artery, we have collaterals from right to left, reversal flow in the left that goes into the pulmonary artery. That results in ischemia and failure, and it can cause failure very early in life. Okay? So we did cover that before as another nice example. See the collaterals from the right to the left, reverse flow in the left going into the pulmonary artery. So here we have an infant with a large heart, some signs of failure, and a brain mass here on the CT. What's going on in this case?
Not cyanotic.
So, child with a brain mass and failure. Vein of Galen. What do we call that? So here it is. You can see this is the vein of Galen that's dilated. A lot of you see the Doppler flow in there. So vein of Galen aneurysm, right? So this condition also really is an AV fistula. And because of that, these patients develop high output failure. So they can also have cardiomegaly with failure. So systemic arteriovenous fistulas. And this is a vein of Galen aneurysm. And the aorta is dilated because of the high output, large aneurysm in this case here, up in the vein of Galen. And so it's really an AV fistula. AV fistula is anywhere in children, if they're large enough, can result in failure, can result in high output failure. Okay? Now, as we've said, if you have cardiomegaly, anything that gives you failure can give you an enlarged heart. So cardiomyopathies from infection, viral myocarditis, that can do it. This condition called endocardial fibroelastosis is where there's diffuse endocardial thickening. So that can result in myocardial dysfunction. Primary form can occur from congenital infection. Secondary forms can occur from severe obstruction of the ventricle, whether it's aortic stenosis, coarctation, hypoplastic left heart. This can cause damage to the endocardial lining and fibrosis, which also results in failure. So that will also give you a big heart failure and can result in pulmonary edema. Congenital mitral stenosis, that's pretty rare. That will give you an enlarged left atrium, okay, in these cases with pulmonary venous hypertension and failure. So here's an example of that. So it's double density back here, big left atrium, congenital mitral valve stenosis. That's a pretty unusual lesion though. All right, so here's another case. Heart's not really big in this example. We do have vascular congestion and failure. Then we have some MR images here. So what's the diagnosis in this case? Well, so this chamber over here is
Left atrium.
left atrium, this guy over here.
Right, and left ventricle.
Left ventricle, this guy over here.
Right atrium.
Right atrium, this guy over here.
Right ventricle.
This guy over here.
That's the aortic.
That's the aortic valve going into the aorta. So which chamber looks abnormal?
The right. Atrium.
Which one?
Right atrium.
The right atrium looks abnormal? This guy looks abnormal, right?
That's true, yeah.
What is this thing in here? No, that's not a jet from, that is not a jet from mitral regurg. That's fixed, you see? What?
No.
This is, say it out louder. Coarctation. Coarctation. So what does this represent?
Septum.
That's a membrane that is going through the left atrium, and that results in obstruction of blood flow through the left atrium because of the presence of this membrane, and that results in pulmonary venous hypertension and failure. So this is coarctation. It looks like there are three atria, right? 1, 2, 3. That's why it's called coarctation, but that's really a membrane there within the atrium. So it's caused by failure of incorporation of the common pulmonary vein embryologically into the left atrium. So that common pulmonary vein forms an accessory chamber in here, separated by the rest of the atrium by this membranous or this fibromuscular septum. And that usually has a small orifice. And because of that small orifice, that results in obstruction of blood flow through here, and that can result in pulmonary venous hypertension and failure. Can be associated with secundum D or partial anomalous pulmonary venous return. So that condition is coarctation. So this extra linear band here in the left atrium is that abnormal membrane, and it causes obstruction of flow through the membrane, which results in pulmonary venous hypertension and failure. So the left atrium might appear enlarged here, but the rest of the heart is not, and there will be pulmonary venous congestion, and can result in, as we've said, failure. So we recognize it by recognizing the abnormal membrane here within the left atrium. Okay? Coarctation. All right, if I tell you that this one, this case, we have failure, we have cyanosis, there's the chest radiograph. What are we supposed to think about when we get this history and a chest radiograph that looks like that?
Total anomalous pulmonary return, type 3.
Type 3, right. So normal heart size with failure, if it's congenital, then we think of total anomalous pulmonary venous return type 3, where the return is below the diaphragm. What happens there is it gets obstructed, that results in pulmonary venous hypertension, interstitial edema, failure, but all of this occurs before we get to the heart, so the heart is not enlarged, right? And these patients will have cyanosis, right? So that comes up a lot on the exam: pulmonary venous hypertension, cyanosis, pulmonary edema, normal heart size. Then we want to worry about total anomalous pulmonary venous return type 3. So the findings on the chest x-ray can mimic pneumonia because of the interstitial findings there. And then, I've given you some other information here also, but the important thing is that the heart size is normal and these kids will be cyanotic. So the abnormal pulmonary veins join here to form a common vein that drains below the diaphragm, gets obstructed. Also, if it drains to the portal vein, as in this case, it's also obstructed there because of the high pressures trying to drain through the portal venous system, and so that results in signs of failure. Okay? So we tell you that this is a neonate, big heart, has cyanosis, pulmonary edema, and there's our MR. So what are we thinking about?
Single ventricle.
Well, let's take a look here. What chamber do we think this is?
That's the right, left atrium,
Left atrium, okay. This guy,
right atrium,
right atrium. Already we noticed what?
ASD,
Large ASD, right? What chamber do we think this is?
right ventricle.
Yeah, so that looks like the right ventricle, okay.
and
Now,
left ventricle.
you said single ventricle. Is this chamber emptying into that? Is the left atrium emptying into that chamber?
No.
No, right? It seems to be emptying into what?
Hypoplastic, that's
Yeah. So this is a very small left ventricle. Also, the left atrium is small, right? So this condition is called hypoplastic left heart. Right? So although it's hypoplastic left heart syndrome, right? You think the left heart is small. Why is the heart big on the chest radiograph? Because what part of the heart is big?
right.
Yeah, the right side.
But
So the
usually
right
it's regular
ventricle.
heart, though, right?
What?
For hypoplastic
No,
left.
hypoplastic left heart is associated with
Cardiomegaly.
cardiomegaly. Yeah, the cardiomegaly, the big heart is the right heart. It's not the left heart that enlarges, it's hypoplastic. So the cardiomegaly is because of the big right heart, okay? So this syndrome, hypoplastic left heart, congenitally, it's probably because of some obstruction of flow through the mitral valve congenitally. And then what happens then is, remember, in embryology, the size of the chambers has to do with the amount of blood flow that's going through them. So with decreased blood flow going through the left ventricle, the ascending aorta does not develop. So we will have severe aortic stenosis or atresia. It can be associated with interruption of the aortic arch. Mitral atresia, that may be the key component here. Small left ventricle, small hypoplastic left ventricle. This is the most common cause of cardiac death in the first few weeks of life, this hypoplastic left heart syndrome. So we get a hypoplastic left atrium and left ventricle. There's left to right shunting at the atrial level here. So the blood goes from left to right through this atrioseptal defect. And because the blood can't get out the ascending aorta, the flow to the aorta then becomes dependent on this patent ductus arteriosus. So the blood flow into the aorta actually gets there through the pulmonary artery and then going through we usually think of a patent ductus going left to right after the kids are born, but here it goes from right to left across there to perfuse the aorta and the coronary arteries. So the right ventricle then becomes responsible for pumping for both circulations, for pumping for both the systemic circulation and for the pulmonary circulation, so it becomes volume and pressure overloaded. There's pulmonary venous hypertension because of obstruction to flow through the left heart. Because of that obstruction to flow, the pressures in the left atrium are elevated. That results in pulmonary venous hypertension. So all of this contributes to failure and pulmonary edema. All right? So there'll be pulmonary edema, there'll be a big heart. A hallmark is a very small ascending aorta. So in this condition, the left-sided chambers will be small and the ascending aorta also will be small. So that small ascending aorta is a hallmark of this condition of hypoplastic left heart syndrome. So here when they inject the pulmonary artery, see that the contrast actually goes across the patent ductus into the aorta to perfuse the aorta. So the right ventricle then becomes responsible for both sides of the circulation. The right ventricle fails, and then the patient goes into pulmonary edema. So for hypoplastic left heart, newborn with cyanosis, CHF, cardiomegaly, increased vascularity. This is the most common cause of cardiac death in the first few weeks of life, is hypoplastic left heart syndrome. Right? And imaging findings, small left atrium, small left ventricle. The ascending aorta here is small. This is a patent ductus arteriosus, so here's the pulmonary artery and patent ductus here. So notice that that's the connection from the right ventricle to the rest of the systemic circulation. And so the right ventricle fails. Hypoplastic left heart. So for pulmonary venous hypertension, if there's cyanosis in the neonate, total anomalous pulmonary venous return, this would have a normal heart size with pulmonary edema. Hypoplastic left heart, this would have pulmonary edema with a big heart. So these are cyanosis failure in the neonate. If there's normal heart, total anomalous pulmonary venous return type 3, big heart, you can think of hypoplastic left heart syndrome. This patient has cyanosis of the left arm and the left lower extremities, and there's a MRA for this patient. Any thoughts?
The left subclavian is like not contiguous or.
Yeah, so here is, where is the discontinuity? The discontinuity is in what structure here?
In the aortic arch.
It's in the aortic arch, right? So it doesn't seem to be connected here to the ascending aorta, right?
Yeah.
So how does blood flow then get into this part of the arch?
PDA?
Like intercostals?
No,
PDA.
PDA. Through patent ductus arteriosus, that provides the blood flow to here, okay, and the descending aorta. So it's going from the right ventricle to the pulmonary artery through the PDA to this part of the body, right? Then what would happen here? Then you would have cyanosis because the subclavian supplies the left arm, descending aorta. So all of this part would be cyanotic. So the lower extremities and the left subclavian artery then would be cyanotic, right? So what is this condition called?
Coarctation? No.
Well, it's worse than coarctation, right? Coarctation, there's still an opening, it's just narrowed. Here, there is no connection at all. This is called
Split aortic arch.
what do you call it if the aortic arch is interrupted?
Interrupted.
Interruption of the aortic arch. Bonus point, what type of interruption is this?
Type 2.
Close, type B.
Ah,
All right.
solid.
So
Type
aortic arch interruption. So this is where congenitally, so this is just like you can have coarctation. So imagine if that progresses, right? It becomes really severe to the point where there is no communication. Then you get interrupted aortic arch. So it's discontinuity of the arch between the ascending aorta and the distal descending aorta. So this can be associated with truncus arteriosus. There has to be a PDA to supply the aorta distal to the interruption, and often it's also associated with a ventricular septal defect, so aortic arch interruption. So that results in pulmonary arterial overcirculation, systemic hypertension, and that can progress to left ventricular failure and pulmonary edema. Because of right to left shunting across the PDA, there is differential cyanosis. So depending on where the interruption is, the part of the body that is supplied distal to the interruption will be cyanotic. If the PDA closes, that's bad, right? That can result in shock or CHF in the first 2 weeks, so that's why they would have to give prostaglandins to make sure that the PDA stays open until they can address the condition. It can also be associated with the Georgia syndrome, bicuspid aortic valve, and obstructions of the left ventricular outflow tract. So, yeah. This is you're not really seeing that, right? So it's back here, it's hidden. This is a MIP, right? So it's hidden. The origin of the vessel is kind of hidden back there. It's still coming off the pulmonary artery. Right. So this image is not to show that. This image is to show the interruption. It's a MIP projection, so you know, everything is superimposed. Okay? All right, so type A is if the interruption is beyond the left subclavian artery. So here we would get cyanosis of the lower extremities. The upper extremities would not be cyanotic. Type B is the most common interruption between the left common carotid and the left subclavian. So here you would get cyanosis of the left arm and the left lower limbs, okay? And then there is a type C interruption between the right innominate and the left common carotid artery. Here also you would have cyanosis of the left arm and the lower extremities. So that's aortic arch interruption with different types. Type B is the most common type of interrupted aortic arch. So you can have pulmonary overcirculation, big heart, pulmonary edema. Trachea may appear in the midline with no arch indentation because of the interruption of the arch. And then depending on where the interruption is, right, you would have higher pressure flow within the intercostal arteries that come off the subclavian proximal to the interruption. So with type A, you can have bilateral rib notching. With type B and type C, the rib notching would be on the right and not on the left because the subclavian in this case would be coming off the higher pressure portion of the circulation. So that's where you tend to get the rib notching. It tries to collateralize to the descending aorta distal to the obstruction. Okay? So the different types of interrupted arch, type A, there's your PDA. So the descending aorta then is supplied by the PDA when we have interrupted aortic arch. Okay. All right, so no cardiomegaly, obstruction proximal to this amount of cardiomegaly, obstruction distal to the mitral valve, cardiomyopathy or left ventricular failure. We've kind of gone through all this already. So let's move on to normal pulmonary vascularity. So when we have normal vascularity without cyanosis, what congenital heart conditions can we have? Well, we can have anything as long as it's mild, right? Any kind of congenital condition, if it's mild, can give you normal pulmonary vascularity without cyanosis. So let's talk about some things that we might come across. A small ventricular septal defect will not give you any abnormalities on the chest X-ray. Remember, we said that the shunting has to be at least 2-to-1 before you actually see changes on the chest radiograph. So the chest radiograph in those cases would appear normal. Here's a 20-year-old man. Here's the chest X-ray. What looks at normal on the chest X-ray for a 20-year-old? What here, if you look at it, you go, gee, that doesn't look right for a 20-year-old. What doesn't look right?
The heart.
Yeah, what about the heart?
Left ventricular enlargement.
Yeah, so why do you think there's left ventricular enlargement?
It's projecting like.
Yeah, so the apex of the heart seems to be displaced downward, right? So that suggests that there's left ventricular enlargement here, okay? So that's certainly abnormal in a 20-year-old. What do you think of the ascending aorta?
It's tortuous.
See it? Yeah, it's tortuous, right? So what might that suggest if you have a tortuous ascending aorta?
Stenosis.
So you might have poststenotic dilatation of the ascending aorta. What else can give you a dilated ascending aorta in a young person?
Marfan's.
Yeah, Marfan's, right? Can that be associated with an abnormality that can give you a big left ventricle? What?
Regurg.
Aortic valve regurg, right?
Yeah.
So Marfan's can give you an aneurysm of the ascending aorta, can give you aortic valve regurgitation, and can give you left ventricular enlargement, right? So let's take a look at this case. So here's our CT. So what can you tell us about the CT here?
Dilatation of the aortic root. Well, dilatation.
Yeah, so there is dilatation of the ascending aorta, right? So we see that aorta is big, okay? So what do we think the cause is?
Well, Marfan's? No?
We have one vote for Marfan's. Anything else? So, yeah, okay, so that's certainly a good thought, right? You could have a bicuspid aortic valve, which can give you aortic stenosis, right? And you can have post-stenotic dilatation of the ascending aorta, so that certainly is, that's also a consideration, okay? Anything else? Does anybody see any other abnormality here?
Um, let's
Nobody sees anything else? What, okay, what are these guys?
the internal memory.
What about them?
They're
Turner
large.
syndrome? No,
Hmm?
never mind. I was saying Turner, but
Aortic coarctation.
Do you see it?
no.
Well, there's dilated intent.
You don't see the aortic coarctation? How about you look harder?
Oh, yeah.
All right.
on the lower left.
Yeah. Look at the descending aorta. Here,
Oh,
here, what happens here?
yeah.
So aortic coarctation on your axial views can be extremely sneaky, okay? You can easily miss it on your axial views. So what are these guys?
Collaterals.
Collateral what? What vessels?
Of them
Those are
from-
intercostal arteries.
Yeah.
So you have dilated internal mammary arteries, you have intercostal arteries that are dilated, right? So this is a case of coarctation. Of course, it's easy now when I show you this, right? No problem here. That's coarctation of the aorta. So let's go back to the chest x-ray. Anything, any clue on the chest x-ray? What?
Rib notching, yeah.
Rib notch, I mean, you guys are convinced you see rib notch. I'm still not convinced I see rib notching on this, but I see. Anything
ribs.
else?
Um,
What? Remember, if you think you see rib notching, what should you look at next?
The aortic knob.
The aorta. What about the configuration of
a
the
three.
aorta here?
The configuration of three.
Yeah, the figure 3 sign,
Yeah.
okay? The way it goes in,
Three.
all right? So the configuration of the aorta. If you think you see rib notching, if you're thinking coarctation, look at the aorta. Do you have a figure 3 sign on the aorta? Okay? So, well, we still have to figure something out. Why is the ascending aorta dilated? Why is the ascending aorta dilated in this patient? We still haven't explained that, have we?
I thought there was, you said bicuspid. That's-
What, trash?
So is bicuspid valve associated with coarctation?
Well, yeah, if the patient had like Turner syndrome, they usually have both.
Well, this patient doesn't have Turner syndrome,
Never mind.
but is bicuspid valve associated with coarctation? The answer is
Yes.
yes. About what percent?
5.
Closer to that, about 70%. Most patients with
70.
coarctation will have bicuspid aortic valve. Okay. So why do we think this person has dilatation of the ascending aorta? Bicuspid aortic valve, and that's it. What else? Anything else?
Post-stenotic.
All right, so maybe bicuspid valve with stenosis, right? There's your bicuspid valve. See the bicuspid valve? Yes? We convinced it's bicuspid, even though you're looking at an echo?
Yes.
Yes. Is it stenotic?
One of the leaflets is not.
Is
opening.
that stenotic? Look how wide it opens.
Yeah.
No.
That's not stenotic.
Okay.
So why is the ascending aorta dilated? No. No.
Hmm.
So, bicuspid valve, even without aortic stenosis, is associated with dilatation of the ascending aorta. Okay? I haven't come across a good explanation why, but you can have bicuspid valve with no stenosis, dilatation of the ascending. That's why it belongs in the differential for young people with dilatation of the ascending aorta. In addition to Marfan's, bicuspid valve can also cause dilatation of the ascending aorta without stenosis. These patients are also at increased risk for dissection. Okay, so bicuspid valve can do all of those things. So that's what we have in this case. Now with coarctation of the aorta, it's divided into two types: the infantile type, where it's kind of more extensive, versus the adult type, where it is more focal. But in reality, it cases tend to be mixtures of both of these, but this is sometimes what the textbooks talk about in terms of how they divide it up. It can also be associated, as you said, bicuspid valve, very high association, VSD, PDA, Turner syndrome. Coarctation syndrome is if you have coarctation with a VSD and a PDA, that will lead to CHF in infancy because you're going to have lots of left to right shunting in that case because you're going to have high pressures on the left side in the left ventricle. Okay? So you can have long coarcs, you can have short coarcs, so there's a variety in terms of what you can have. And then we talk about different pressures, right? For coarctation, the pressures in the legs will be different than the pressures in the arms because the lower extremities are distal to the obstruction. The notching is caused by hypertrophy of the intercostal arteries. Remember, the intercostal arteries come off of the internal mammary artery. So the side of the internal mammary, and these intercostal arteries will try to provide collateral flow to the descending aorta distal to the obstruction. So it is where the internal mammary artery comes off the subclavian in the high pressure region of the circulation. That is where you get the dilated intercostals, and that's the side where you get rib notching. So if the coarctation is here, distal to the left subclavian artery, right, then here you would get rib notching on both sides. If for some reason the coarctation were over here, proximal to the left subclavian artery, then the rib notching would occur where?
The other side?
Only on the right side,
Yeah.
because the left side is not in the high pressure region of the circulation. Okay, so that can be a way to approach questions about what side you get rib notching, depending on where the coarctation is located. So venous hypertension, pulmonary edema, cardiomegaly, of course, if it is severe, if there's an associated VHD and PDA, then the failure can get even worse because of the overload of the left ventricle. So we talk about looking at, in addition to rib notching, look at the configuration of the aorta, look for that figure 3 sign. If we're thinking about coarctation of the aorta, here's an example of rib notching, right? And here the aorta goes in a little bit. Here's another example of some irregularity there in the contour of the aorta, big left ventricle. There's a coarctation, right? And then for the esophagus, if you happen to do an esophagram, we call it a reverse 3 on the esophagus. The indentation of the aorta on the esophagus gives you a reverse figure 3 sign, okay, for coarctation. You will have collateral vessels. We talked about the intercostal arteries trying to provide flow to the descending aorta, distal to the obstruction. The internal mammary artery, of course, is also dilated. In these cases, can be associated also with cerebral aneurysms. Coarctation can be associated with cerebral aneurysms. Dilated internal mammaries, dilated intercostal vessels. If we see that, that tells us that the coarctation is hemodynamically significant, right? If we see that. So here's our coarctation, nice demonstration with MR. This one has left ventricular hypertrophy, has coarctation there. Now, how do we determine hemodynamic significance? Well, first, if we have collateral vessels, right? If you have dilated collateral vessels, then we know this has to be hemodynamically significant. Is there another way with MR to show hemodynamic significance of a coarctation? What do we do with phase contrast? What can you do with phase contrast?
Before and after the coarctation, we can measure the velocity.
So what are you measuring? Where are you going to measure, and what will you measure? Where do you take your measurements, and what do you measure?
Oh, actually, we'll do the measurement.
Anybody? Well, here, distal to the coarctation, you can do a phase contrast measurement of the flow in the aorta here, up here in the proximal descending aorta, okay? And we compare that to the flow here in the distal descending thoracic aorta. Under normal conditions, in a normal patient, which flow is greater? The flow here or the flow here in a normal patient? Which flow is greater? Proximal. Why?
More proximal to the heart. And there are many vessels going out of
What vessels?
intercostal.
The intercostal arteries, right. So under normal conditions, the intercostal arteries take blood flow away from the aorta. So under normal conditions, the blood flow here will be higher than the blood flow here. Now, as you've said, when you have a hemodynamically significant coarctation, the blood flow in the intercostals is reversed. So they're trying to carry blood flow to the descending aorta distal to the obstruction. So in that condition then, where will the flow be higher? Descending, right. So if you have a hemodynamically significant coarc, then the flow down here will be higher than the flow there. And so that's where you do your measurements with phase contrast. Right? So phase contrast, we take measurements of the flow in the proximal descending aorta, compare it to the flow in the distal descending thoracic aorta. So under normal conditions, the flow in the proximal aorta is greater than the flow in the distal aorta, but if you have a hemodynamically significant coarc, the flow in the proximal aorta here is actually less, as the flow in the distal aorta, because of the reverse flow in the intercostals, is increased. Right? So that is one way of doing this. Right? Now here, in this example, we have a nice turbulent jet. Now what else can we do to also examine this? What's something else we can do? If we have a jet, what can we do? We can calculate the pressure gradient across the obstruction, right? How do we do that? You do have to know this equation because they do ask you this.
So I say it's like
So
the-
what is the equation? So based on peak velocity, if you measure the peak velocity in your jet, what is the equation to calculate the pressure gradient? So 4v squared. So if you express peak velocity in in meters per second, your peak velocity, the units there, meters per second, 4v squared gives you the pressure gradient in millimeters of mercury. Okay? They do ask you this. They will give you a peak velocity and they will ask you what's the pressure gradient. So you have to know this. Okay? So in this case, well, if it's greater than 15 to 20 millimeters, that's considered a significant gradient. So that's another way of describing the obstruction there, how severe the obstruction is. Okay? Now, treatment of coarcs, they can be treated with balloon angioplasty. So here's an example. There's the coarc, balloon angioplasty. These patients require follow-up because the coarc can recur. They can develop pseudoaneurysms at the repair sites. So these patients do require follow-up imaging. Here's an example. Can this be anything else except coarctation of the aorta?
A web, because you get carotid webs.
What is this called?
Pseudocoarctation.
Pseudocoarctation. So how do you know it's not coarctation?
No collaterals.
There's no collaterals, right? So pseudocoarctation looks just like coarctation, except it's not a hemodynamically significant obstruction. There are no collateral vessels in this case, okay? And then there will not be a significant pressure gradient across this. That is pseudocoarctation. Maybe it's a form of coarctation that really is not severe. Maybe it's just redundancy of the vessel that folds on itself, but this is called pseudocoarctation of the aorta. Same morphology of coarctation, but no obstruction of blood flow. Right? So that's called pseudocoarctation. There's no rib notching. There is no, and there are no collateral vessels. Right? So that is pseudocoarctation of the aorta. Okay, so let's move on. Funny looking chest X-ray. So let's examine this a little further. So this guy, what is that guy? IVC. That's important because that's going to take you to, where does it take you? Right atrium. What will this guy be?
Left atrium.
Left atrium. Now we got to figure out these guys. All right? So when you look at these guys, these are ventricles, obviously. Right? So what do you think? What do you think they are? So we have these two ventricles here. What do they connect to?
Okay, there's no transposition at least. uh,
Pulmonary?
Well, what is this guy?
aorta,
Aorta. What is this? So what vessel is over here?
pulmonary trunk.
What did you say, Jose?
Pulmonary trunk? No,
You said there's no transposition.
I think there's no transposition.
There's
The aorta is coming from the left ventricle.
Well, what's the morphology of that ventricle? What is that guy going across? That's a moderated band. But this ventricle is also increased in trabeculation, right? So what's the morphology of that ventricle? That's a morphologic right ventricle. So this would be a morphologic left ventricle. That morphologic right ventricle is connected to what structure? Aorta,
Aorta.
right? And then that morphologic left ventricle. So this is the morphologic left ventricle. That guy is connected to pulmonary artery, right? So there's a transposition. So the morphologic right atrium here is connected to what chamber? The morphologic right atrium is connected to a morphologic left ventricle. The morphologic left atrium is connected to a morphologic right ventricle. This is atrioventricular discordance. And we have ventricular arterial discordance. What is this condition called? No. This is L-transposition or congenitally corrected transposition. Right? And then one key to making this diagnosis rather quickly is if you look at the relationship of the ascending aorta to the pulmonary artery, right? What do you notice about the position of the aorta relative to the pulmonary artery?
Anterior to the right,
Anterior and to the left.
to the
Usually in transpositions, the aorta is anterior to the pulmonary artery, but in detransposition, the aorta would be anterior and to the right. In L-transposition, it's anterior and to the left. So that's a very quick way of making a diagnosis in these cases. So this is a case then of congenitally corrected transposition. So here is this ventricle over here, right? And this is a morphologic right ventricle. Notice the separation between the inflow and the outflow valve here. What do we call that? This ventricle has an infundibulum, right? The separation of the inflow and the outflow valve, this ventricle has an infundibulum. So that is a morphologic right ventricle. Okay. On the other side, you have fibrous continuity here between the inflow valve and the outflow valve. That is a morphologic left ventricle. Okay, that's why it's important to know the morphology of the ventricles when you're trying to diagnose these congenital heart conditions. So this is congenitally corrected transposition. Atrioventricular discordance with ventricular arterial discordance. Okay, the aorta is anterior here to the pulmonary artery, anterior to the left in cases of L-transposition. Also notice that the coronary artery anatomy is also kind of reversed in these cases. So you have the anterior descending artery here coming off the right coronary artery. Okay? So that also occurs, is that the coronary anatomy is reversed with L-transposition. Now it's called L-transposition not because the aorta is to the left of the pulmonary artery. It's called L-transposition because embryologically this results from an L loop. Normally the heart forms a D loop in embryology to form the normal heart, but when we have congenitally corrected transposition, the heart goes through an L loop, and that's why it's called L-transposition. But it's congenitally corrected, so the atria in correct position, but the ventricles are kind of reversed. The ventricles are twisted so that they connect to the wall chambers, right? And then, because we have transposition, the blood flow from the right atrium still winds up going into the pulmonary artery, the blood flow from the left atrium still winds up going into the aorta in these cases, right? So we still have transposition, we still have ventricular arterial discordance, but the oxygenated blood still gets into the aorta, and the deoxygenated blood still gets into the pulmonary artery. So that combination of atrioventricular discordance with the ventricular arterial discordance winds up the blood flow getting to where it is supposed to go. I've also given you this diagram showing you the relationships of the aorta and the pulmonary artery in these various conditions. That can be very helpful to help you make a quick diagnosis if you're just looking at these imaging cases, especially differentiating D from L transposition by the locations. So that's important. Normally, the pulmonary artery is anterior to the left of the aorta. When you have D transposition, the aorta is anterior to the right of the pulmonary artery. When you have L transposition, the aorta is anterior to the left of the pulmonary artery. Just knowing this can help you make a very quick diagnosis when you're looking at a case of transposition. As we said, the blood flow still winds up going to where it is supposed to go. So why is L transposition bad? What makes L transposition a bad thing? Why is L transposition bad? Well, that's one problem. One problem is over the long term, the right ventricle fails because it's not designed to handle systemic pressure over the lifetime of the patient. The other problem is the associated abnormalities. Usually there are associated abnormalities like there could be pulmonic stenosis, there could be ventricular septal defect, problems with incompetence of the tricuspid valve or stenosis of the tricuspid valve or Epstein's-like malformations of the tricuspid valve, which in this case occur on the systemic side, so they can kind of mimic the symptoms of in a normal patient, mitral stenosis. So it's the associated abnormalities in these patients that get them into trouble. Also conduction abnormalities in these patients, because the bundle branches are also twisted in these patients because of the embryology. So with L transposition, the ascending aorta rises like this to the left of the pulmonary artery, and that can be a key finding. So here we have pulmonic stenosis in this case. There's a ventricular septal defect, the aorta arising to the left side of the pulmonary artery. So that aorta arising on the left of the pulmonary artery can be a key imaging finding for L transposition. So the shadow of the ascending aorta to the left of the pulmonary artery. In this case, there's a VSD, which causes the increased pulmonary blood flow. So that's what we see with L transposition. Aorta anterior to the left of the pulmonary artery, ascending aorta to the left of the pulmonary artery, atrioventricular discordance and ventricular arterial discordance, and then here the ascending aorta here to the left, arising on the left side of the mediastinum, is a plain film finding associated with transposition. They can also have a juxtaposed right atrial appendage, which helps to contribute to this abnormal border on the left side of the mediastinum in these cases of L transposition. But with one image, you can make the diagnosis. If you notice that the ascending aorta is anterior to the left of the pulmonary artery, you can make the diagnosis of L transposition. Okay? So ascending aorta rising to the left.